Thank you, Kristen. I'm actually joining you from Market Harbour, which is just inside Leicestershire in the UK. But I did want to say a shout out to my colleagues, Jennifer Fang and Julianne Piper, who've contributed a lot to the work that I'm about to present. So they are joining you from the West Coast, Coast Salish, traditional and unceded territories. Okay, so that's my title. And really, I wanted to really build on the 2 days that we've had, which have been excellent. I've listened to most of the sessions. I've found them very informative, very important ideas. And the purpose of our session today is really to try and be forward-looking in what can we do about a lot of the issues that were raised over the last 2 days. And so just to maybe summarize some of the issues that have been raised, but to go a bit further, I guess, to contextualize the talk that I'm going to give. I mean, we've heard that already that historically, previously, with major infectious disease outbreaks, there's been really limited use of travel restrictions, and they've been largely frowned upon and advised against, being largely counterproductive. And so when COVID-19 was started and declared a public health emergency of international concern in January, WHO did not initially recommend any use of travel or trade restrictions based on that previous experience. But what we saw then was virtually all IHR states parties actually adopted some form of travel measure. Some of them were restrictions, others were other types of measures. So there's a big debate about whether these states parties were compliant or not with international law. The public was initially quite supportive in general to these measures, but then as time went on, it was, and there was sort of prolonged use of these measures, fatigue set in, confusion, some frustration, and certainly opposition over time. Interestingly, the science also progressed during this time, and we saw travel clearly being shown as a key variable in the spread and the continued spread and ongoing emergence of subvariants, variants, due to largely the genomic sequencing data. But that's been a very clear finding. And also that there's other evidence that showed that early use of these travel restrictions in a precautionary and quite stringent way actually was warranted for reducing importation and onward transmission. So we got all of this kind of swirling around in the last 2.5 years. And what the focus has shifted now to is trying to recognize, not just say, no travel restrictions ever, but to recognize when, what, and how to use these travel measures when you have these sorts of very major infectious disease events. And here's just some of this, evidence, because I heard over the last day or so, people saying, well, there's no evidence of effectiveness. Well, there actually is, and I just wanted to show a few slides. The genomic sequencing data is very clear. The evidence around comparative analysis of different interventions is clear, and systematic reviews of the evidence, largely modeling studies, but some observational studies show that travel measures can be effective. So I just wanted to say that, so to stop people saying that there is no evidence out there. But where we're at now, and interestingly, it was only a month after the fake declaration was made, that WHO started to really soften some of its initial, recommendation against travel measures, and said that, well, we don't, generally encourage the use of those measures, those restrictions. What they can be justified if you have a careful risk-based kind of assessment of whether they're needed or not. So that was interesting. It's quite early on, just a month after the fake declaration. So fast forward, we're now very much talking about this. What is this risk assessment? What is this risk analysis that WHO called for? And increasingly, other governments, private sector, and international organizations are hoping that would emerge. So that's what I'm going to talk about. So let's start maybe from basic principles. What is a risk? A risk is basically a possibility of some negative event, which we often call a threat or a hazard, actually occurring. And that can adversely impact something that we value. It could be health and well-being. It could be the natural environment. It could be wealth generation and accumulation. Whatever we value, there's a possibility of something occurring that will harm that. And risk analysis generally, if you look at some of the frameworks, divides analysis up into 3 components: assessment, management, and communication. And this is just a really standard way of sort of breaking down the analysis itself. And you can apply this kind of framework to specifically travel. And that's been done for a long time. I mean, if you think about when you go traveling, your institution might advise you to, whether you should go or not. Like if you're in a university or part of government, you can go online and, see what the advisories are. So this is a kind of a routine thing that governments and organizations do to flag, to maybe identify potential threats if you're a traveler going somewhere else. So you're an outgoing traveler. And that's, as I say, a very routine thing. And then if you're specifically interested in sort of what the health risks are, travel medicine often deals with travel-related health assessment. For incoming travelers, the analysis would focus on, what risk does a traveler coming into your country pose to your domestic population or your domestic environment. And so that there's methodologies to have to do with that. But largely what's the shortcoming of these current travel-related risk analyses are, the methodologies, is that they tend to look at threats as out there coming in to threaten domestic populations over here. And so the methodology tends to be framed in this way. And what we really need, what we've learned from COVID-19 is that these risks and these, these threats are very interconnected when you have a very globalized population that is moving about through first, second, third countries, when there's trade relationships and so on. So the methodology is a little out of step with the kind of risk assessment and risk analysis that we need. So as to say, WHO started to already shift its focus to risk assessment by February, but actually didn't put out guidelines or formal guidelines. It had a lot going on, so it took some time to do that, but did put out a document in December 2020, just an initial guidance to provide countries looking to conduct this sort of analysis. And then later it was revised and updated in July 2021. And what we're seeing now is an emphasis on encouraging countries, member states, to continue to develop this approach. But since 2021, there's been so much going on. And really, it's been put out there for, I guess, scholars and international lawyers and others to think about as something that needs to be advanced. So our team, Jennifer, Julianne, and I, we looked at, well, we got to take these methodologies forward. Let's see what has already been attempted. What methodologies are out there that we could get our hands on, and how can we look at what parameters they looked at, how they actually conducted these analyses. So the 11 methodologies are listed on the left here. And what we found was that there are quite a lot of variation in, when we had these 6 parameters that we compared them against, we found a lot of differences across these methodologies. Things like what they considered the main source of the hazard beyond the virus, who is actually at risk, how you actually characterize the risk. And what's interesting is what level of risk is actually deemed tolerable, because obviously if you have a higher or lower level of tolerated risk, then your policies are going to be very different at the border. So much variation, and this really explained why countries were so different in how they actually practice border management. And so just a quick caveat that that we didn't, we weren't able to dig that deeply because a lot of these methodologies are not very available in the public, even though many, and probably most governments would claim that they use the risk-based approach. We could only really get our hands on 11. WHO's methodology provides a kind of decision instrument or a tool that kind of takes you through, if this, then that. And it lists some of the variables that you should take into account if you're considering the use of travel measures, and they're listed here on the left. And so this is the sort of thing we looked at. We looked at what exactly what variables were being looked at, how did they assess them, what sources of data, and so on. And so WHO was the only one that provided this kind of very clear decision tree, but others we had to sort of look through guidelines and a little bit opaque documents, trying to figure out what actually policymakers claim to do, whether they actually did these things, that's another story, but we couldn't really assess that in our analysis. So just identifying, coming up to my final slides, is what do we need to do to move forward? And one of the things that we've concluded is that it's not helpful for the IHR in future to just, or for WHO to declare if there's a public health emergency, all countries need to do X, because actually, it can vary from country to country. And so it's really important to maybe think about how we might agree a process of decision-making, but you may end up with very different answers. So there's three parts to, I think, what we're recommending is really, first of all, what we're finding, and even in this conference, although the terminology is improving, it's still, a lot of people speaking about different things in different ways, and often they're speaking at cross purposes. So we really need to agree internationally, some standardized terminology about what we mean by a border measure or travel restriction, a border closure, and so on, because those sorts of things are really important if we're going to compare like with like, and then advocate accordingly. The second part of this slide is really a chunk of considerations, part of a risk assessment to some extent of whether or not to use travel measures and how you would use them. So, first of all, the pathogen obviously takes precedent. Is it the type of pathogen that requires travel measures to be used? Is it a respiratory infection? Is there asymptomatic transmission? What is the incubation period, and so on? So these very basic science things need to be understood. Sometimes that's not available, but based on what are travel measures warranted? Secondly, looking at the jurisdiction that you're governing, do you have a strong healthcare system? Is it robust? Is there already this pathogen in your jurisdiction, and so on? What is the geography of your jurisdiction? There's all sorts of things that would feed into whether travel measures are actually appropriate. And the third one is really the politics. What are your priority goals? Is it elimination? Is it suppression? But also, what are your principles? How much equity are you trying to achieve? Who are you trying to protect? Who's at risk in terms of priority? And then along come things like exemptions that you need to think through, compensation, and so on. So those are very important risk assessment considerations before you even get to the kind of what we call the formal travel-related risk analyses that you find in those 11 methodologies. So these are kind of like your homework before you even get to applying the methodology. And that homework really shapes how you and what you do with those methodologies. So that's really a key finding, is that there's not one way to do this. You really have to grapple with your normative framework, values, priorities, politics, alongside the science before you can do any principle. So finally, my last slide really is, okay, we've been talking about revision of the Article 43 in particular, and we haven't, I'm sort of divided, I think, on whether revision is needed. On the one hand, the use of additional health measures already has these principles. And I agree that it's a terribly badly written article, and there's all sorts of room for interpretation. So there may be arguments to clarify some of the meaning and to sharpen it up in terms of what exactly is intended. There might be two ways to revise the article that from our research. One is to think about what compliance means when people are talking about non-compliance. But if you look at these principles, a lot of countries probably thought they were complying actually with the Article 43. So, it's not that they were deliberately non-compliant, but that they actually that the article is not very clear. And the second is, how do we deal with the precautionary principle? And that's something that isn't dealt with in Article 43, and that may be something to consider. And I apologize for going over time. That's me. Thank you.
Wonderful. Thank you so much for that, Kelley. I really appreciated your points on the need for clarity and terminology to think about when travel measures are appropriate. And then your last point about, who are we trying to protect? This is a really valuable way to open the panel. Okay, let's move on to our second paper, Border Closures, the Intersection of Law, Epidemiology, and Politics. And we have Stephen Hoffman and Patrick Farfan to present this paper. Stephen is the Professor of Global Health, Law, and Political Science at York University. And Patrick is a Professor of Public and International Affairs at the University of Ottawa, here in Ottawa. Okay, over to you. Thank you.
Great. Thanks so much. Can I just confirm that folks online can hear? Yeah, you can. Perfect. Oh, it's not on? Is it on? Oh, it's now on. Okay, excellent. I hope everyone can hear me. So before Patrick and I present, just first, what an amazing conference. This has been Colleen and colleagues, Sophie, others at the University of Ottawa. Thank you so much for bringing this together. I think if the pandemic has showed us anything, it's how precious these opportunities are to be in person and online for those unable to be here, but also how much they're to be treasured, because it's not something that can always happen. So a big thank you for this. The second caveat, just before I jump into the slides, and I hopefully have the ability to control the slides. Is that maybe with you, Patrick? Just wanted to just emphasize, at least for me, I have two jobs. So this is actually the first time I'm presenting as a researcher while having a government job. So really just want to emphasize I'm presenting as an independent researcher. And what I say today definitely does not reflect the views of the Public Health Agency of Canada or Government of Canada. And on the bottom. Okay, thank you. And so myself, my background, I'm a lawyer and epidemiologist. Patrick, as a political scientist, means I'll talk about the law and epidemiology. Patrick will be speaking about the politics. So I wanted to bring us mentally back to January 2020, a little bit of a traumatic time, I guess, for probably all of us. But the reason I want to bring us back is just to emphasize that we slowly saw over the course of really only 2 months progression from a world where travel for, well, those who are lucky to have good passports or passports that allow travel to be able to travel, to a world that slowly saw greater numbers of restrictions, more and more over time, to the point where by May 1st, 2020, over half of the world had almost total border closures. Those that were left with targeted border closures, 38 countries at that point, still all those other countries had sort of gone through that at one point. And the reason I want to emphasize that is because this highlights how much in dialogue our presentation is with what Kelley just presented, what others earlier in this conference talked about. And so from this perspective, it really highlights how much we went through something that was rather unprecedented and how little guidance there was before this reality to inform what should be done in this reality. And so that being said, we do, of course, still have law to look to. We have epidemiology to look to, and we do have politics. And so our job today is really to explain what went on, what are the factors, and what does this mean for the next inevitable pandemic. To start with the law, I actually will be, I think it's actually clearer than maybe has been articulated. And because when it comes to the law on border closure, at least the international law of border closures, it's actually very clear, and there isn't actually very much controversy. Basically, all the international lawyers who focus on global health in the world all agree, because we came to a consensus statement on it, that most COVID-19 border closures were illegal under the international health regulations. Of course, there's a question as to whether it should be illegal and whether that should be the content of the international health regulations. That is a live question, which I'll come to in the second part of this presentation. But the fact that under Article 43 of the International Health Regulations, a legally binding instrument, it is a super convoluted way of writing about what countries are allowed to do. But it is clear that additional health measures by countries, such as closing borders or imposing additional requirements during pandemics, are only allowed if 1, they're supported by science, 2, they're proportionate to the risks involved, and 3, they're respectful of human rights. And so just a very quick analysis as this slide, it's maybe too small for folks to see, but a very quick analysis highlights that these, it's coming one at a time. These requirements were not met. So first, in this case, while there was not very wasn't a lot of scientific evidence about the effectiveness of border closures. Most previous border closures had been targeted border closures, and the few studies that were conducted about whether they'd be effective generally showed they weren't. And so there's a study looking at border closure in Nepal, in Guinea, in Mexico. There was actually a systematic review of the published evidence that was published just in January 2020. So there is an up-to-date evidence base highlighting that targeted border closures were unlikely to be effective. There were some modeling studies highlighting maybe a border closure can buy you 3 days. So does that work or not? Well, it works for 3 days if that's the intended goal. If it was beyond that, maybe not. Of course, we now have the ability to evaluate. And in fact, my next slide will be pointing to what we can learn from COVID. But the reality was that the international legal obligation, as per the IHR, demands looking at the science of the day, what was known at the time, and targeted border closures were the preponderance of evidence highlighting them not to be effective. As well, in this case, WHO specifically recommended against them, as Kelley highlighted. And indeed, in terms of human rights, Article 3.1 of the IHR demands that all health measures be implemented with full respect, the dignity, human rights, fundamental freedoms of persons, and many border decisions around the world seem to be made on the basis of the color of citizens' skin, as opposed to on the basis of risk in the way that Kelley described. And so with that in mind, there is still a live question, which I'll point to next, about the epidemiology of border closures. So they were clearly, in most cases, illegal, the targeted ones. There is a live question, I'd say, or a nuanced question about whether total border closures, so border closures that didn't allow anyone in, that were not disproportionately affecting any population, that were equally targeting everyone in the world. There is a live question as to whether that would be allowed under the IHR during COVID, because there was no previous science about that. So there wasn't a preponderance of evidence against that intervention. But it's clear for most cases in most countries, they were illegal. Whether they work, this provided an unprecedented natural experiment for us to take stock now and improve on the evidence to inform the next outbreak. And so myself working with, trying to make this work. Before launching into the study that we did at the Global Strategy Lab, wanted to emphasize one of the first things when we think about border closure that we have to consider is that a border closure is not an on and off switch. There's actually at least 6 different border control strategies that countries around the world utilized. And the first one can be seen as, well, there's as none. A second strategy would be an early total closure. So that would be, for example, like Slovakia. Third would be a late total border closure. That'd be like Mozambique. Fourth, there could be targeting a few countries. South Korea, for example, targeted China. And then what you'll see in that figure, I hope you can see it, the red line is showing what percentage of the world's cases of COVID-19 were included in that targeted border closure, as opposed to the world's population, which is the blue shading. A next strategy, a fourth strategy, would be focused on targeting many countries. So for example, Sweden would, over the course of the pandemic, over the first early months, increase the number of countries to which its targeted border closure applied. And then the last one would be taking a continual adjustment approach, which is what Japan did, adding and removing countries based on what they articulated to be a risk-based assessment. Let me skip this just because of time. Do border closures work? It's a good question. This was a natural experiment, an opportunity to think about it. What we did in the lab is we tried to bring together some real-world data around drawing on COVID-19 case data. We were able to convert that data in 166 countries to reproduction numbers. And then basically what we were able to do is take stock of, as countries implemented different kinds of border measures, did it change the reproduction number of COVID-19? And so we specifically used 2 different quasi-experimental methods. First was, I won't go into all the details, but the first one was interrupted time series analysis for those who have a bit of a quant background. We also, adding on to that ITS analysis, we did a meta-regression analysis, which allowed us to identify what factors were associated with effective closures versus ones that might be less effective. And we used just a second method, coarse and exact matching, which allowed us to reduce the covariate imbalance between those countries that did have border closures versus those countries that didn't. Our point in using two separate methods was hoping we'd get the same results by using two different methods, which we did get. And that was hopefully going to help us emphasize that our findings, which I'll show on the next slide, are not just an artifact of a particular statistical approach, but actually reflect an underlying phenomenon. I won't go into all the numbers because I don't think this is the place to do it, but I did want to point to our findings. And from our perspective, this, as far as we know, this is the first quasi-experimental impact evaluation ever conducted on national border closures. Means that once it's published and it's in a revise and resubmit right now, it would be, in our view, the most rigorous evaluation ever conducted of national border closures. What we found are three important findings, which I'll show right here on the slide. The first was that, yes, total border closures, and to a lesser extent, targeted border closures, did temporarily slow COVID-19 transmission within countries. The key being it slowed it. It was a temporary slowing, and the value of that slowing entirely depends on what countries do to make use of the time that they bought. So it's a very big intervention to impose, for example, a total border closure. It's a huge disruption. The value of that will depend on how much countries make use of the days, couple weeks, 3 weeks time that they've bought. If they're able to make good use of that time, maybe it's worth it. Maybe that border closure worked. If a country doesn't do very much during that period that they've maybe bought by slowing down the arrival or transmission, then did the border closure work? Well, it did slow it, but value of a border closure is a separate question and depends on what you make use of the time to do. The second is that, and this very much aligns with Kelley's earlier comments and the amazing work that she and colleagues have been doing throughout the pandemic, is that late implementation of border closures reduces their effectiveness. That maybe is an obvious thing, but what it points to is the difficulty in operationalizing the precautionary principle for measures during a pandemic. There are about 200 events every year that have pandemic potential. If we, knowing that late implementation reduces the effectiveness of these border measures, one would say, okay, let's implement early and fast, no regrets. The problem is you can't do that for 200 events every year. We'd be always having our borders closed. The third is around that, and this is maybe, I think, the most interesting one, is that what we found in our meta-regression analysis was that what mattered more about whether a border closure was effective when it came to targeting was whether a country targeted a larger proportion of the world's population rather than a larger proportion of the number of COVID-19 cases. Another way of rewording that is that those countries that tried to pursue a data-driven approach, or at least claimed to pursue a data-driven approach in terms of adding or taking countries off targeted lists, they would have done better had they randomly selected countries to impose on a travel restriction list, as opposed to taking a risk-based approach, which was based primarily on COVID-19 data that was available at the time, but which of course is always at least 14 days old or more, given it takes time for people to exhibit symptoms, people to go to a hospital, get tested, for that data to be reported. And so the biggest important thing was for determining the effectiveness of a border closure was what percentage of the world's population was covered, not the percentage of COVID-19 cases that was covered. And so going to, oh, I'm sorry, I was looking on my screen and I had all of that written down on here that could have helped, but I walked through it. I hope it was clear to those. Those are my three key points that I just walked through. And then just going briefly before turning over to Patrick, trying to get this to work. Going up then from a global perspective, if you were the head of the World Health Organization, you need to know though, okay, what's very clear, and I 100% agree with Kelley, that the effectiveness of these types of measures depends on the individual country circumstance, for sure. For example, New Zealand was able to, in the early part of the pandemic, make good use of the fact that it's an island country, COVID had not arrived on that island country in the initial very early days, and they were able to see what was coming based on the spread in other countries. But if you're looking from a global perspective and you're trying to reduce the spread globally, do you get all countries in the world to just shut down their borders? And actually, in a way that Colleen aligns with the question you asked about, could every country just do this? And the short answer would be yes. If all countries did actually shut down their borders, our analysis shows that, yeah, that would result in a significant reduction in global transmission. The key is for it to be significant, it has to be a total border closure, not a targeted border closure. And so again, the practicality of that kind of approach is quite difficult. I know I'm starting to run out of time. So just to say, I presented one set of analysis. We additionally actually did 328 robustness checks and sensitivity analyses because we know this would be a bit of a maybe controversial finding and such. And in the process of peer review, kept on asking for more and more, well, what if you change this variable? What if we lag the variables in this way and such? We got 328 of those. And so once this is published, we're actually going to publish as a web appendix all 329 analyses that we did, the primary one and the 328. They'll all be in a web appendix. Patrick, over to you.
Okay, so if the punchline of the presentation is that total or even partial border closures are some combination of a violation of international law and or ineffective, the question then is, why do governments do it anyway? So if this were a pure public health presentation, this is usually where some variation of the concept of political will is invoked, or lack thereof. And if I could be so bold in an audience of lawyers, from a political science perspective, the fact that states did not abide by their treaty obligations under the IHRs is not in the least surprising. So I guess my punchline here is to simply say, and if you go to the next slide, I mean, I won't go through this. It's just to say that in political science, we have a whole body of theory and concepts and research and theory that explains this kind of behavior on the part of states. So I'll just draw your attention to the box in the bottom left, which is sort of domestic consideration. What states actually do is a function of domestic politics. This is kind of axiomatically true for political science analysis. The good news is we can actually think about this systematically. We have tools, we have concepts, we have models. And so we can do much better than conclude, oh my goodness, states didn't live up to their treaty obligations, or states did not act in the way which the best available evidence would suggest. We can actually do much better than that and give explanations that are more robust because at the end of the day, our goal is to maximize compliance. So I'll stop there.
Thanks very much. Thank you for those very terrific remarks. I was really kind of drawn to what you were both saying too about the value of the border closures depends on what countries do with the bought time, and then the remarks that Kelley was making too about there's some ambiguity about what border closure means. So I look forward to returning to that in the Q&A. We're going to turn next to Timothy Evans. Timothy is the Director and Associate Dean of Population and Global Health at McGill University, and his paper is Global Health Law Overcoming the Shortfall in Human Resources. I did want to flag that Timothy has to leave at 3:40, so we'll prioritize questions for him. So if the audience can just keep in mind that we'll go right to him before he has to depart in the Q&A period.
Great. Well, thank you very much. And thanks, Colleen and crew, for organizing a great event. And I'm only sorry I haven't participated more. I'm quickly learning to become a lawyer, which has always been a lifelong ambition. But I'm going to talk about, surprise, surprise, that we need more lawyers. So this is a slightly not specific to borders per se, but more to global health law. And I look forward to all sorts of recommendations from you with respect to how this chapter might move forward. I'd like to begin with an acknowledgement, which is that I have the privilege of working on the traditional unceded territory of the Kaneaka the place which has long served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and Anishinaabe. And as white settler, I also acknowledge the harms and mistakes of white settlers and the advantages I've undoubtedly derived from these. I'm going to talk a little bit about the evolving context of the global health workforce and global health law, because I see this as a microcosm of the issue. And if in fact we were going to go to total border shutdown, I would argue it's impossible because we don't have the human resources first and foremost. But I'm not saying that we can't do anything. There's all sorts of interesting things, and I'll put forward some propositions for being able to better respond to growing needs and demands in global health law by particularly looking at the role of academic institutions. So a little bit on the evolving context, which is a massive chronic shortfall in health workers globally back in the SDG era, that's sustainable development, the MDG era, Millennium Development Goals. We estimated that it was about 3 to 4 million workers that were missing, and in related not only to absolute numbers, but also the types, and that's very important for this discussion, their distribution, quality, safety, leadership, all in deficit. Fast forward to the MDGs and forecasting need and labor market demand, and those figures, both in terms of needs and demands, inflate to somewhere between 10 and 30 million, depending on how you want to bring need and demand. So huge shortfalls with respect to supply. COVID has accentuated this, so we have an acute on chronic labor shortage, and we're seeing that as we speak. Someone just sent me a terrible article from La Presse showing the situation in the Saint-Justine pediatric emergency room in Montreal, 150% bed occupancy, staff completely overwhelmed, burning out, workforce attrition. We've got the acute on chronic challenges that we're facing. So we're into a brave new world of global health, and Richard Horton's talked about the syndemic. It's just not the infectious, but there are all sorts of other big problems related to NCDs and socioeconomic or structural inequalities. And then Srinath Reddy, who's the master of alliteration, says that viruses cross borders, but so too do unhealthy ultra-processed foods, sugar-sweetened beverages, transnationally marketed maladies, and aggressively advertised addictions. So if that wasn't a clarion for global health law, I don't know what is. But these two former leaders, heads of states, also said, we can't do this alone. And therefore, there has to be some collaborative arrangement, which again, invokes treaties and all sorts of agreements where the law has a lot to offer. Right, so when we think about the global context for health education or health professional education, we have 4 big buckets that we've looked at, which relate to these emergencies: pandemics, syndemics, climate change, underlying systemic inequalities, which are probably getting worse, systems performance shortfalls, and then health tech and digital futures, which have both great opportunity and great peril. So brave new world of global health, how do we think about that with respect to health law competencies? So pre-pandemic, a few of the things that when I was at WHO, we worked on: ethical recruitment of health workers, Framework Convention Tobacco Control, International Health Regulations, Commission on Intellectual Property, Universal Health Coverage. All 5 of those areas had major resolutions within 2 years at the World Health Assembly. And one of the things that was always present in those negotiations is that high-income countries came with 20, 30, 40 lawyers. Low-income countries came with none. So massive inequity in the design of those from the outset, because the voices required to give fair representation with the requisite competencies were just not present. Post-pandemic, it's getting more complex. We've got the mandates, lockdowns, the systemic inequalities, raising really important issues of things like paid sick leave. How do you manage rapid regulatory approvals? What is the legal framework for advanced purchase agreements, which is part of Canada's success in getting all those vaccines, the TRIPS waivers or other compromises or challenges to the TRIPS regime, and trade and travel restrictions, of course, amongst them border control and vaccine passports. Larry Gostin, a big leader in this field, has just come out with his new book, Global Health Security. And in that context, throwing down the gauntlet again, that we really have to move forward and navigate this brave new world that we live in. And I like to refer back to Thomas Homer Dixon, a Canadian who wrote about the environmental crisis 20 years ago, and his attention to an ingenuity gap. Because given the nature of problems that we're addressing and the rate at which they're coming, our primary rate limiting step in addressing them is mobilizing the ingenuity to solve them. And if you want a really very uplifting read, there's a new book called Decline by a guy called Andrew Potter, which shows the rate at which we're losing our ability as a civilization to engage in collective problem solving. So in some sense, it's the flip side of the coin of Thomas Homer Dixon's book. So some starting points for moving forward. Look to history. This is one of my favorite reports. Sir Edwin Chadwick reported the sanitary conditioning of the labor population. Crises create new demands for health professionals, and it was the crises in the port cities of the UK in the 1840s that led to the creation of a district medical officer. And this was how it was described in that report. And the last sentence there, responsibilities to initiate sanitary measures and reclaim the execution of the law. And so I think we should be thinking, as Chadwick did, about the sorts of professionals we need to engage in the crises that are ahead of us. The Lancet Commission, and by the way, I do not work for Elsevier. They issued a report in 2019, led by Larry Gostin and the O'Neill Institute, on the legal determinants of health and harnessing the power of law for global health and sustainable development. And they came up as legal determinant for the imperative of building legal capacity for health. And these were the three intersecting then dimensions of that capacity: an effective legal environment, strengthening the evidence base, and Stephen's just given us a great example of that. But the one I'm going to focus on is empowering the health law workforce. This is the IHR, 13 core capacities for implementation by all countries by 2015. The first was national legislation, policy, and financing. I put that up there because that requires a lot of health law capacity. But then number 7 is human resources. And if you look at the way that that's framed, competent, skilled health personnel for sustainable and functional public health surveillance. So it's limited within the context of the IHR. They didn't say anything about legislation or border closing or anything else. But they do say effective implementation of the international health regulations. GHS index and joint external evaluation tool, both of which have shown to have no bearing on COVID response, but both of which are being revised, look at human resources in various ways as part of their assessment of whether countries are ready to either implement the IHRs or deal with pandemic crises. For D, under detection, is where the human resource is fit into the IHR tool, JEE, Joint External Evaluation Tool. And these are the criteria along which you can address and assess your capacity. Again, a capacity that's very limited to one area of the IHRs. Canada reported its implementation of the IHRs in its report in 2017, and they deemed they'd made significant progress in developing the public health workforce. They had a diversified workforce that had all those cadres, no mention of lawyers, health, public health, or otherwise, or border or immigration officers, legislators, or human rights. And then it said Canada has the ability to mobilize public health staff anywhere within the country. I guess they were referring to the Army. Sorry, there we are. They do have good plans, though, and this workforce planning was a nice document from 2005. Really actually mentioned the importance of public health lawyers and building on strengths, a nice, very comprehensive building block approach, but we've not seen any evaluation of the implementation of that in a serious way almost 20 years later. Sorry, I'm getting a little, there we are. So academic medicine needs to take a little more responsibility. In the chapter, what I've tried to do is look at the global supply of training in health law by WHO region. And as you can see here, Euro and, which is Europe, and PAHO, which includes Canada, are way out ahead in masters in health law and diplomas, and also courses in legal epidemiology or equivalents. But you can see EMRO, we couldn't find one course or program. AFRO, very limited, mostly in South Africa. And WIPRO, Western Pacific, mostly Australia, New Zealand. So we're looking at this. This is impartial. This is very early, and I'm sure if I'd appreciate any advice and recommendations on things we're missing on this. But I think getting some map of the distribution of that capacity is helpful. I was part of another Lancet commission in 2010, which looked at health professionals for the 21st century. And it is updating its recommendations more than 10 years later. And I wanted just to finish on that, because I think it's not back to academic function as usual. We really need to move the needle in terms of how we think about both instructional and institutional reforms based on technological platforms which are enabling of the education process. There are some things out there that I think are pretty interesting. You guys know more about them, but the legal epidemiology competency model that CDC pioneered, I think coming out of Burris transdisciplinary approach to public health about 5 or 6 years ago. I know others here are involved on that front. But I think that's going to be important in moving things forward. And then to think about strategic shifts in the way we organize education, from being closed to an institution to having a more open architecture. Standardized experience as moving to responsiveness to diverse needs, and front-loaded education to education for life. And I say that very particularly because one of the things that I learned in developing this chapter, I think I'm losing battery on the shift. Oh, there it is. No, I missed the slide. Well, maybe not. Anyways, it's that we really need to be looking at opportunities to engage people at different parts of their career to promote leadership. So not just people pre-degree, which would be future leadership, but those that are into workplace, getting mature and moving to maturity, and opportunities for giving them competencies that would allow them to contribute, drawing on their experience. This was the 3 stages of the legal epidemiology career development that I found on the CDC website, which looks at entry-level, mid-tier practitioner and professionals at a senior manager, principal investigator level. And I think thinking across that spectrum is going to be very important for mobilizing the full global health workforce. So finish by saying, can't solve a problem on the same level that was created. You have to rise above it to the next level. So thank you very much for your attention.
Terrific. Thank you so much, Tim. Great ending quote as well, too. So we're going to move on to our final speaker for the conference, and also one of the organizers of the conference, Sam Halabi, Senior Associate Vice President for Health Policy and Ethics and Professor at the Colorado School of Public Health. And his presentation is on reforming the world's approach to infectious disease threats. Over to you, Sam.
Thanks so much, Kristen, and thanks as well to Colleen and Giles and the people who make these conferences possible. I always come away sort of enriched and with a much deeper understanding of so many issues. So I'm glad to be part of it. And given that I know Tim will need to leave us in about 15 minutes, I'll try to speak quickly so we can prioritize questions to. I thought it was. It is on. Okay. So my topic is really reforming global health law and especially what those reforms look like with respect to the borders theme. So really, I'm going to sort of in very broad strokes walk us through a couple of processes that are underway internationally. One is the reform of the IHR 2005. That's been mentioned a number of times over the course of the conference. Some of us spend our days and nights with the IHR, others of us don't. And some of us have been tracking and following and supporting the new international pandemic agreement process very closely, and others haven't. So I am going to do a little bit more detail just for those who don't spend their days and nights with it. So just to state very straightforwardly, and my background is in international law, under default rules of international law, governments are under no obligation to report incidents that happen within their legally recognized territories unless a treaty or rule of customary rule of international law provides otherwise. That is the gray zone in which the IHR 2005 exists. That is where a lot of the dilemmas and difficulties have arisen. So to some extent, this is easier to rehearse for a Canadian audience. The IHR 2005 originated with what was essentially sort of a preview to what happened in the last 2 years, right? So a novel pathogen emerged in central China. Regional health authorities were alarmed and didn't know what it was. The National Ministry of Health said that the novel pathogen was contained, delayed reporting to the international community. It ultimately spread across the globe. Within 4 months, there were around 8,500 cases and 800 deaths. And it was that absence of legal authority, and particularly by the World Health Organization, to demand information from the government of China or another government that caused those revisions to be taken, to be undertaken. And COVID-19 has shown that the changes that were adopted weren't enough. So I'm going to oversimplify, especially, given Lisa Foreman's sort of very detailed and 100% correct analysis of Article 43, and I think Kelley Lee's very effective sort of support of it, to say that there were 2 main components to the IHR 2005. Number 1 was an obligation to report to the World Health Organization through a national focal point. And number 2 was for countries to be prepared. And that was all listed in Annex 1 core capacities. After those things happened, the Director General of the World Health Organization was supposed to direct the international response, and governments were supposed to listen to him or her. None of that really happened, right? So 2/3 of countries never fulfilled their commitments under the IHR 2005 to adequately prepare. Almost all of that was because they couldn't afford to do so. Even when events were detected early, countries were incentivized to hide rather than disclose information because other countries imposed punitive measures for doing so. right? So one of the most illustrative episodes of that is sort of South Africa's sort of very early and very bold decision to disclose the Omicron variant, after which it was effectively punished by the international community, including by the United States and Canada. The IHR 2005 never made any commitment by wealthy governments to ensure that life-saving medicines, vaccines, or medical equipment flowed efficiently, equitably, or rationally to the people and places that needed them most. Indeed, rich world hoarding of vaccines and medicines has been predictable and persistent. Not only willful neglect of resource inequality, but few or no mechanisms for accountability, dispute resolution, or incorporation of rapidly advancing technologies and transfer of those technologies doomed the IHR 2005 in its current iteration. In November 2020, Charles Michel, who was the president of the European Council, began circulating the idea of an international pandemic agreement, given the IHR 2005's deficiency. He met with Tedros, a lot of us know Tedros, the Director General of WHO, who agreed that it would finally provide a mechanism of accountability where the IHR 2005 had failed. On May 21st, 2021, the World Health Assembly, which is the governing body of the World Health Organization, agreed to call a special session to consider that pandemic agreement. And the decision in December of 2021 was to establish what's called an intergovernmental negotiating body. It's the same kind of negotiating body that preceded the Framework Convention on Tobacco Control, the World Health Organization's only binding Article 19 treaty. The IHR, separately, the IHR 2005 was opened for revision and amendment. To date, 14 governments have proposed amendments to the IHR 2005 addressing various aspects. Not all of those proposed amendments are publicly available, at least not so far as I know. The most available and the ones that I think reflect sort of how borders might change under new international regimes are those submitted by the United States government, which was the first and probably most extensive, the Russian Federation, which actually submitted on behalf of 5 countries, so Belarus, Armenia, Kazakhstan, and Kyrgyzstan, and the Russian Federation, and then the African, essentially the Afro region governments submitted by the permanent mission of Eswatini in Geneva. So over the course of summer 2022, the World Health Assembly appointed a working group to start to develop a draft text, to hold informal consultations on what might be included in an international agreement. And it has focused those conversations on intellectual property, equity, law and governance, and the theme of One Health. And we can talk a little bit more about how One Health is defined in the Q&A. The working group recommended a new binding treaty to be established, although it left itself wiggle room. For those of you who know the WHO Constitution, Article 19 is its treaty provision, Article 21 is its regulatory provision under which the IHR 2005 was issued, and Article 23 is its recommendation authority, under which it's undertaken most of its activity. Separately, a review committee that performs the IHR has been convened. Participants in this conference are members of that review committee, and that committee will consider, among other things, proposed amendments. In broad strokes, the proposed amendments by the US, the Russian Federation, and the WHO Afro governments, both point to borders becoming more rigid in a kind of traditional international law sense. For example, controlling information, blocking access to information, but at the same time ease borders, right? So there seems to be some consensus around the supply of medical products and the ease of migration of healthcare workers during times of emergency that emerge as themes. So I don't know at the end of the day whether borders will become more permeable or whether they will become more strict and more controlled. All of these are possibilities. So just a few highlights from the United States. So the United States calls for the Director General, in addition to the temporary measures authority now available under the IHR, to be able to deploy expert teams as part of temporary measures. That's a response to perceived hesitation by some governments, and really, I think we can go ahead and say the PRC, because that's what the United States has in mind, to allow international investigations, as well as closer coordination with other international organizations and exemptions for healthcare workers from travel and trade restrictions. I think if you were taking a skeptical or cynical view towards those proposals, the United States is attempting to sort of encircle governments where outbreaks occur, not just with the World Health Organization in some measure because it believes the WHO has failed in reporting and responding, but to include FAO, IATA, ICAO. So the United States wants more international organizations to be able to be part of the response in addition to WHO. The United States also asked for the emergency committee to be diversified and include regional directors, and also calls for the establishment of a compliance committee with broad powers to seek expert advice, request action from the Director General, and coordinate with other international organizations. The United States also, in its proposals, asks that either a country respond to WHO or that be legally determined to be a refusal to cooperate with WHO, at which point effectively sanctions would be triggered. The Russian Federation, oh boy, the Russian Federation.
Sorry, I'm just going to try and join.
Got it.
I'll do it with it.
The Russian Federation, again, submitting on behalf of the Eurasian Economic Union, calls first for legislation ensuring national focal points, the communication backbone of the IHR, are actually able to perform their functions. There is abundant evidence, some of it produced by Kuman and Wilson and myself in a project sponsored by the World Health Organization, that even though national focal points were supposed to be the clearinghouse and the backbone for the reporting of information about outbreaks, they've been underfunded, they've been subject to political influence, they've lacked the legal authority to undertake their positions. Sorry, Tim. Thank you. And therefore, the Russian Federation proposal requires actual statutes be adopted that give the NFPs that authority. On the one hand, that addresses something that's sort of deeply internal to how governments make decisions for themselves. On the other hand, it speaks to how real effective epidemic response and control is going to depend on more of a window into how governments functions, thus penetrating borders, at least with respect to the national focal point function. The African region, the proposals submitted by the government of Eswatini, representing the 47 WHO Afro governments, have been far more broad. So they call for equity and obligations on prevention, detection, and control of pandemic threats, provision of financial assistance and technology transfer to developing countries, subjecting all WHO actions in a pandemic under the provisions of the IHR and a complementary future international instrument, an obligation to provide support to WHO to coordinate the response, ensuring equal footing of pathogen and genomic sequence sharing and benefit sharing. Speaking to some of the issues that I raised earlier with defects in the IHR 2005 originally. I'll close just by saying that we really don't know what's going to happen with the International Pandemic Agreement. There's a draft text issued in July that was very broadly worded, and at least so far as it reads, unlikely to be adopted by a threshold number of member states of the World Health Assembly. There's going to be a subsequent text that's developed over the course of the autumn and released in February. Under the terms established by the World Health Assembly in 2021, there's supposed to be an entire draft text completed by May of 2024. It is lightning speed in the world of global diplomacy and international lawmaking. There's a real question as to whether or not there was a mistake to commit to that kind of hastened timeline so early in the negotiations. But maybe it will ultimately do what I think the WHO legal secretariat wants, which is sort of force governments into either developing something that will satisfy all stakeholders, particularly internal stakeholders, or look like they're doing nothing, which I think is ultimately a more paralyzing fear. Thank you.
Thanks very much. So we have a few minutes for Q&A. I just wanted to flag for the panelists that there have been some questions posed in the Q&A online. And Sam, if I could ask for your help with regards to people in the room, because I can't see from my angle whether there's ones there. I just wanted to kick it off with a question that can perhaps be combined with the ones online, just to keep things efficient. My question for the panelists goes to this question of the new pandemic agreement, and specifically what the panelists think is the capacity of our provincial and federal governments to implement our meet our obligations under international law. The WHO Convention on Pandemic Preparedness refers to multi-sectoral and whole of government responses in Provision 8, for example, and I'm just wondering whether the panelists think that we actually do have the capacity to implement these international obligations as it currently stands. As I suggest, maybe we can combine that with questions from the room or with questions online. Sam, if you could help me with that, I'd appreciate it.
Yeah, absolutely. Well, so Kristen, just to be clear, you can see the questions in the Q&A box. Yes. Okay. So maybe I'll just ask Colleen or Lisa or the gentleman I have not met, if that question is consistent with anything that you were going to ask to be combined. Okay. Then maybe, I mean, as the Canadian experts, I'd probably defer to Stephen and Patrick.
Sure. Actually, Patrick, you're probably better placed to answer that great question. I'll be just very brief, which is that Canada is one of the richest countries in the world. We have some of the best systems in place to be able to respond to the full range of public health issues. So I guess, yeah, Kristen, I'd hope if we can't figure it out in Canada, I guess I'd be worried about how are other countries going to do it. Of course, Patrick, as a master of federalism, is probably better placed to handle, but it's in some respects, that's the beauty of living in a federation, is having these opportunities to figure out how do we work together across jurisdictions to fulfill needs that we need to figure out for citizens in our country. But the dynamics of it, Patrick, you're probably better placed to figure out.
I'll be very quick. Before I returned to academia, I spent a number of years in government, including doing a lot of intergovernmental relations. So on public health generally and the IHRs in particular, it's a good news, bad news story. So the good news is the pandemic led to levels of intergovernmental cooperation that were unheard of, that had never been seen before, and new mechanisms were established that were, or an intensity of interactions that was dramatic. And whether they'll persist is a whole other matter. But Canada, unlike some other countries, did not have quite the level of intergovernmental bickering that happened in some other federations. So that's the good news. The bad news, and Stephen, take this in the spirit in which it's the nicest possible way, the government of Canada is congenitally incapable of linking its international obligations to its intergovernmental relations. It's just not in the DNA. So it will be a challenge. Maybe the government of Canada is up to it. I don't know, we'll see. But to have the detailed kind of conversations that are required that Tim Evans was talking about around HHR, and linking what Canada may or may not want to commit to in a treaty with what is actually possible on the ground in areas of provincial jurisdiction, is within the realm of imagination. It would just take, it's kind of a bit of pulling against gravity. So we'll have to see.
And I'll just add, from the US perspective, where there's a similar problem, so there were reservations, for those of you who aren't of international law backgrounds, are essentially permissible exceptions taken by governments when they join a treaty or agreement. So two of the most problematic reservations entered in the IHR 2005 were by the United States, saying in essence, it wouldn't enforce the obligations if they were otherwise constitutionally dedicated to its subnational governmental units. It has the authority to compel that compliance. It just chose not to do so, as did China, right? So it's a critical gap. And one of the remarks I've made in this sort of broader discourse is that those kinds of reservations should at least be subject to a more intensified debate as either the IHR 2005 is amended or as a new agreement is developed. I think Colleen is next.
Thanks. That was another wonderful panel, and thanks to Kristen for moderating, and thank you so much, Kelley, for coming in from your trip. We really appreciate it. My first question was really for Patrick. You didn't have much time to present, but I don't really see what's in it for governments from a political perspective to close borders, particularly as they did away all around the world. I mean, generally, you know, everybody wants their borders to be open for tourism, for traffic, for trade, for all sorts of things. I mean, that's kind of the rationale for the whole, you know, free trade and so on. And I know from sort of some inside baseball experience from New Zealand that certainly wasn't, the rationale was really they were doing that calculus on the back of the envelope about the number of hospital beds and how quickly their healthcare system would be swamped. So it wasn't some, let's be mean to I don't know who by closing our borders. So there's that question. I'd just really like to hear a little bit more about why you think that would be the case. And then I was just reading when the World Health Organization, information at the beginning of the pandemic again, when they were saying, don't close your borders. And at the same time, they were saying, wash your hands. The first thing they said was you have to wash your hands. Masks, they, are useless. Don't use masks. And if you have to use a mask, be very careful about how you dispose of it. So when you read those edicts at the time, almost all of them turned out to be wrong. And I guess it goes back to one of the questions that came up before was, if we are in the IHRs going to embolden or empower an entity with a lot of say about what different countries can and can't do, how do we make sure that they are getting it right and not inadvertently getting it really wrong? So kind of to come back to the federalism point, one of the reasons we kind of argue for federalism is, we let everybody do different things and then we will see what happens and then the best thing will rise to the top. Sometimes we argue that, right? So anyway, so two questions, but I was puzzled by, and I know you didn't have much time, Patrick, but I'd like to hear.
So there's a long answer and there's a short answer. The short answer goes something like this. And Kelley may have some views on this as well, but think of what it was like in Canada and indeed countries around the world in the period February, March 2020. Basically, we were very scared and we didn't know what was going on. And so the public was demanding the governments do something, right? And so in that period of time, it really was a mixture of do something that works, or at least do something. In other words, because you're not giving us a lot of choices as citizens as to what to exercise agency. So part of what happens with border closures is it's theater's too strong, but it's a form of being seen to take action when you're not quite sure what else to do. That'd be the first point. The other, and I'll just end on this observation, is the difference between what is rational and what is politically makes sense. So that yes, for trade reasons, for tourism, the economic impacts of total or partial border closures are enormous. From a rational point of view, you would never do it. But from a political point of view, when the public is asking for it, and if you're in the United States or in Brazil or in other countries whose leaders fermented that idea, the political calculus is quite straightforward. Let me give the example of Australia, which we talked about yesterday. Despite all the declarations to the contrary, Australian states close borders as between them, however irrational it would be, right? So I'm not making an argument here, but that's a good idea. I'm just saying that observationally, we observe that there is a political calculus that leads governments to close borders, however irrational it would be. But we can think about it systematically. And if we're building treaties, we can potentially build counter incentives so they're somewhat less quick to go there.
Kristen, I don't know if there's a question in the Q&A that we should take online or if I should go to Lisa.
Colleen had a second question.
Oh,
The Q&A question was for Dr. Hoffman. Some countries, Taiwan, New Zealand, South Korea, acted early, i.e. ahead of WHO declaration of the PHEIC, and applied the precautionary principle. It's also very clear that in the case of Taiwan, Korea, and Hong Kong, early actions were spurred by prior experiences with SARS. One of your slides on IHR Article 43 seems to imply these early actions are actually illegal.
Yes. Yep. They were illegal. So the ones, so South Korea, for example, is an example of a targeted border closure, which at the time, the proponent's evidence was against the effectiveness of targeted border closures. I think it does, though, that question does point to Colleen's second question, where I think you very very beautifully raised the hardest part of all this, I think, which is around the interface between science and law, which is that on one hand, we want, of course, evidence-informed decision-making. We have an example here where we built that in to an international instrument, and maybe in the end, the science given the examples that we had and the limited ability to evaluate, that science pointed us against something that maybe could have been helpful. And it also highlights that science evolves and our knowledge evolves. One of the strengths, I think, of instruments can be that they have an automatic updating mechanism by reference to science. But what happens in those rare situations where maybe the science gets misapplied from previous examples to new realities where it's not directly applicable and such? But that's, I think that's a really, really difficult question to reconcile, and speaks to the question from online, because for those countries that did do total border closures, where it's a question mark, in my view, as to whether that was legal or not under the IHR, because there weren't previous examples of total border closures that had been evaluated. It highlights how difficult it can be to balance that tension, and what do global lawmakers or member states, WHO in the cases that Sam was talking about, what does that leave them then to do in trying to both encourage science, but recognizing that there will be situations where that ends up being difficult to reconcile with as science evolves, and questions about whether that was good. And a lot of people who want to judge decisions on the basis of what we know after the fact and with the benefit of hindsight, as opposed to judging it based on what knowledge was known at the time, which I think is fair enough. We need to hold people accountable for that, but probably a balance of holding people accountable for what could have been known at the time versus, of course, what we can learn based on with the benefit of hindsight for the future.
Let's
Could I jump in, Kristen?
Oh, sure.
Well, I've just been listening. First of all, we really have to get the terminology right, because very few countries actually close their borders. I mean, trade continued. There's a hell of a lot of exemptions. And so Canada never really did close its borders, along with every other country. There are very few examples of this. So using the Oxford data set is actually not very helpful, because they sort of very crudely characterize countries that actually really just basically did not close their borders. So there's a problem with the data set that's used to kind of describe these countries and their policies. That makes research very difficult, of course, and comparing like with like. But the other issue is, I don't agree that countries were illegal in what they did when they used the precautionary principle. I mean, there was certainly non-compliance with some of the provisions under the IHR. But if you look at this provision about having to be based on scientific principles and available scientific evidence, if that evidence doesn't exist, or it's irrelevant, or it's out of date or inappropriate, are countries supposed to then just follow what was just follow WHO recommendations? And that even WHO will now admit that that was the wrong thing to do. So it's really confusing to say to countries what you did was illegal. If it was illegal, then the law is an ass, obviously. So what isn't really helpful is to categorize virtually all countries as having violated international law. A more useful way of doing it is to understand why the international law wasn't appropriate, and to then provide suggestions on how it can be improved. And that's sort of where our work comes in, is where there may not necessarily need to be a revision of the IHR Article 43. It might be clearer guidelines in an appendix or a separate guideline. So that's where I think where the debate should lie. And interestingly, the review committee actually doesn't have any proposals yet submitted on Article 43, which is concerning. So anybody on that committee needs to maybe suggest that. I don't know if it has to come from states parties, but that's a big oversight. All of these 2 days that we're spending time looking at this may be for naught if it's not even on the agenda.
No,
Thanks,
it's a good point that I meant to mention. They need Lisa's help to read it. Lisa Mormon.
What a fantastic panel. Just look behind me and saw there's a long line, so I'll try to keep my comments short. I just want to note how incredibly exciting it is to hear a director of a School of Public Health talk so excitedly about the imperative of having global health law competencies. And I hope Tim will be hiring widely the brilliant young scholars who are coming up in this field, giving them opportunities. So I have a question for you, Kelley, and then a question for the panel in general. Kelley, I really enjoyed your presentation. I wondered if you could clarify how you see the precautionary principle working alongside a risk assessment, or do you feel that a precautionary approach precludes a risk assessment? I also wondered if you could speak more about the way that you see the efficacy of travel restrictions over time, and whether there's any light between in terms of duration, in terms of the stringency that you're seeing. And the second question to the panel is to pick up on a really provocative question Colleen asked earlier around whether the balance should be in the IHR between public health, addressing public health risks and managing traffic and trade. So I would love to hear the perspectives of the panelists on, is this the right grand bargain? And if it's not the right grand bargain, what should it be otherwise?
I'll try and be quick. Good to see you, Lisa. And thanks for that excellent question. So they would be alongside, as far as we're working this out, but coming up with some sort of decision instrument. The precautionary principle would come in when you're looking at the pathogen characteristics itself. So not every pathogen that comes along, and Stephen, not every disease outbreak news that comes along, you put border measures on. It's only certain types of pathogens, certain types of events. As I was saying earlier, respiratory infections of, perhaps of unknown cause, that there's certain incubation periods, there's certain maybe asymptomatic, the lack of treatment, whatever. There's certain criteria I think infectious disease specialists could come up with that would be the sort of alarm bells, and those would justify a precautionary approach. It would be time limited. It wouldn't be, as we have seen, these measures, being prolonged, but they would then allow a deeper dive into the risk assessment, risk analysis, and you would go in and, then really look at your jurisdiction, look at your principles, et cetera, and decide. And importantly, it doesn't have to be border closures. Rarely do you use border closures. You could introduce screening, advisories, testing, quarantine. There's all sorts of measures at, before, and after a border. And those are border or travel measures that you choose from, and you have to then apply the right ones to the right context. So, we need to get away from that binary, let's just slam the door shut or keep it open. There's so much more nuance that we need to build into this risk analysis than we're discussing in this panel. And this is the sort of work that we're trying to do. It is a complex challenge analytically as well as practically.
Great, thanks very much. So I've been told that we can go to 4:10. I just wanted to go back and have a look at some of the questions that have come in online. Tim Evans in particular sent one, I think, in transit. So I wanted to pass that on. Is there evidence on the effectiveness of border closures within states such as the Atlantic bubble, or closures of access to nursing homes, long-term care facilities that could be used to triangulate international findings? Maybe I could put that on the table. I don't know if anybody wants to answer that now, or we can combine that with others.
There is, and I think some of the previous panels have actually discussed that.
Okay.
And it's, there's all gradients about social distancing and mobility restrictions. So yes, there is a lot of evidence.
Thanks, Kelley.
I just want to say two quick things. One, oriented toward Lisa's second question, which is sort of, no, there's travel and trade shouldn't be part of the IHR. That is a path-dependent legacy of the conferences from the mid-19th century, where it was just European countries preoccupied with the disease threat posed by cholera, more or less, right? I think it was David Fisman's presentation. That said, I don't think there's a meaningful way to extract them. I mean, I think they're too threaded into the agreement. They're actually, so I am personally aware of evidence from Hong Kong and Singapore, where as a result of SARS and H1N1, they actually had pretty well developed plans for their senior care or elder care homes. And at least in the near term, as with the sort of border measures, they appeared to protect those populations relative to those in countries that didn't have that kind of preparation.
May I?
So Colleen has asked that sort of you, who I do not know yet, Adam and Kumanen, sort of go ahead and state your questions in succession, and then we'll answer them in turn.
Okay, is this on? So I'm Dylan McKelvey. I'm a policy analyst at the Public Health Agency of Canada. This relates closely to Colleen's first question, and then Professor Fafard, your points that you made. So we've talked about the actual efficacy of border closures in terms of stopping transmission or importation of COVID. We've talked about groups or classes of persons that are unduly impacted by border closures, as well as the legality of them under international law. So in terms of other rationales for border measures, strict ones, we've had strict domestic measures in place throughout the pandemic, on and off here. To what extent do you think that maintaining border measures encourages our population domestically to comply with or follow local public health measures? Accepting that that would not be a viable or justified rationale for closing the border to increase domestic compliance, but do you think that has an impact? If we had done away with our measures earlier on, would we have as much compliance with domestic measures? Thank you.
Yeah, no, I think Adam will go, and then Kumanen will go.
Yeah, all right. This is mostly for Patrick, but Sam, maybe there's an American equivalent here as well. Since just having some poli-sci at the table here. So in terms of like the pandemic treaty, you know, at the point in Canada where in the leadership race for the official opposition, you know, not the winning candidate, but potentially winning candidate made opposition to the pandemic treaty a central platform of the campaign. You know, how feasible is this going to be domestically to do and to participate in negotiations and then ultimately to sign on in your view?
I'll be quick, and I apologize, this was discussed earlier. Stephen, didn't you publish an article saying international treaties don't work or matter? And in that context, what are we doing?
Okay, so there are a couple of questions on the table. One is the relationship between what Canada, or for that matter, any other country does in terms of its international obligations, and what signals does that send to domestic populations, and could it potentially be an incentive? And then Adam asked a much broader question about the sort of the politics of Canada or any other country living up to its international obligations. On the first question, it seems to me that I would actually, my first instinct would be to argue the reverse, that a border closure is politically, or at least a partial border closure, or at least being seen to be engaging in border closure activity, has lower political cost than imposing lockdowns and making vaccines mandatory and making or curfews, as Quebec tried. In other words, if the cost of your response is borne by others, then there's a political argument in favor of doing exactly that. Similarly, that's why we love vaccines. Vaccines are a politically low cost technological response, and that's why politicians like them so much. So it strikes me that, and by extension, I don't think there's a demonstration effect. I don't think that most people in their minds care much about consistency between what their government does internationally and what they do domestically. As to Adam's question, it's a very provocative question, but it's kind of important. And I'd be interested in what Sam has to say. There's an assumption in public health and in global public health and global public health law that we live in a multilateral world and that countries will respect their international legal obligations, and we have consensus that's the world in which we want to live. And I think the pandemic should at least have shaken that set of assumptions. And the rise of populist governments around the world, generally speaking, these are people who don't much care about, even if there are huge economic costs, don't much care about maintaining the liberal international order that was built up over the last 100 years. And so our challenge is potentially much deeper, because in our politics, there's a whole lot of what would have been called at a different time, isolationism. This is, again, I'm not asking you to like it or not like it. I'm just saying that it is a theme in domestic politics. And before Canadians think, oh, well, that's like other countries do that. I mean, I think those of us who live in Ottawa and lived through the occupation, it is part of our politics as well. And it's not going to go away. And the only question is, how our political system channels those debates? I think so far the answer is it's doing a good job of it. Dr. Lewis did lose, but it is a reminder that it's there.
Happy to quickly address the two questions that were directed to me. I think, Lisa, I love your question about the what's the right grand bargain. I think that's the question we have to answer. I can say, though, it seems like a new grand bargain is starting to emerge in negotiation already. And that grand bargain is, instead of between travel and trade and public health, it's between being willing to provide surveillance data and being able to report, and equitable access to countermeasures. So that is likely the grand debate that I anticipate would emerge through the negotiation of a pandemic instrument. Whether it gets resolved in a good way will depend on member states engaging in that negotiation and how they do it. The quick answer, well, Kumanan, my team just published an article, the title of which is "Most International Treaties Fail to Achieve Their Intended Effects." That is true. We looked at 200 studies that evaluated different treaties. Most treaties do fail to achieve their intended effects. The exceptions are trade and finance treaties, which do promote trade and finance. And the exception are those treaties that have enforcement mechanisms. So when I'm being asked for advice on design of new international laws, I'm very happy to give advice. I always follow that advice with, but to make this really matter, we need to include strong enforcement mechanisms. The IHR does not have that. That is one of the questions then about whether, does it really matter? Well, if you're an international lawyer, you care about international law, and you care about countries being in compliance with it and not doing illegal activity, whether that's maybe overall that should be done or not, which is a lovely thing about this conference, because the interdisciplinarity, I think Kelley and I, for example, we're speaking to similar points, but actually coming from different perspectives. Kelley as a political scientist, an IR scholar, myself, international lawyer. So in that respect, I think when you're right, does this all matter? Well, I think if you're interested in promoting public health and designing instruments that are better, there's a lot we can do better in this space. This is not a very well-designed instrument. But if you do care about the rule of international law, then it is a separate question about our countries in compliance, and don't we want that? And I think an international lawyer would say yes. Yeah, thanks.